All right, so without further ado, good morning, good afternoon, and welcome to the 14th GPC Key Populations Community of Practice. Today, we are diving into the Global Fund's Grant Cycle 8, or GC8, as you will hear it called today. And specifically, we are talking about prioritizing programming for HIV prevention for key populations. This is the first of two sessions today, and there will be another session this afternoon to accommodate different time zones. I'm Heather Marie Schmidt, the advisor for HIV prevention program implementation, which is part of the GPC Secretariat, and I'm jointly funded by UNAIDS and WHO, so I'll be your chair for this morning's session. Today's webinar is available with French, Portuguese, and Spanish interpretation. So if you need that, please go to the bottom under More and select your preferred language. If you have any problems, please just use the chat. So a few housekeeping things. We are curious to know who is here and where you're from. Please do say hi in the chat and let us know. However, when we are asking questions and you would like to raise anything or get clarifications from our speakers, please do use the Q&A function that's down the bottom. And this will just help us find your questions so that we don't miss them. That Q&A function we will then also use. We'll try and answer as many questions as we can, but we will also use it in the discussion. If we have time, we may also be able to, you may be able to raise your hand and ask your question live, but please do put it in the Q&A function. So today's webinar, as I said, is based on the GC8 grant applications. And the first window for those and the second window is in just a few months. So writing is already beginning in many countries. The world is in a very different place than it was during GC7, which I think all of you know very, very well. And there is a much more constrained funding environment. There have been important moves that have been taken towards integration, sustainability, and country self-reliance. However, there are still really important gaps in HIV prevention, and some of them have been exacerbated by this situation. This is especially true for HIV prevention for people from key populations. Meaningful participation of key populations and community-led organizations in GC8 planning and writing is critical. So the next slide, please. With this in mind, the objectives of this webinar are to share evidence to support key population networks, implementing partners and governments in prioritizing programming for key populations in GC8, to deepen all of our understanding of the key tools that are available to support the development of key population prevention sections in GC8, proposal writing or proposals in general, and to learn from our government and our community network colleagues about how to advocate for and to ensure effective prioritization of key populations in the Global Fund proposal. So our first speaker today is Matteo Castellato, who is the Technical Advisor for Key Populations, Community Rights and Gender Department at the Global Fund. Over to you, Matteo, to talk about prioritizing key populations in the GC8 application.
Thank you very much, Heather Marie. Hi, everyone. Good morning, good afternoon, depending on where you are. My name is Matteo, and as I said, work at the Global Fund as a key population advisor. So if we go to the next slide, I'll start giving you a bit of an idea of what are some of the strategic shifts that are taking place in terms of, about the Global Fund when it comes to key populations programming and the HIV response in general. And what you can see here is basically that there is definitely a big push to make programs more sustainable. And how do we do that, though? Well, there are a number of ways to do that. realistically, we're talking about increasing financing from domestic resources. We're talking also about trying to slowly transitioning key populations programs and the HIV response in general that is funded by the Global Fund to other sources of funding, primarily domestic ones. This also means, as you were mentioning, Heather Marie, relying more and more on integrating interventions into wider primary healthcare services. Now, when it comes to key populations, though we know this is a difficult journey, it's also a difficult ask. That is why I'll be speaking more about, what are some of the mitigation measures and some of the work that needs to be done to ensure that, key populations program can realistically be integrated into primary healthcare. If we go to the next slide, I just want to touch base quickly on the type of funding requests that are available to be used for GC8. And so you'll see on the right-hand side, there are two main application packages. One is for high impact and core portfolios, and it's a full review application package, which is very similar to what we had in GC7. When it comes to focused portfolios and countries on an accelerated transition pathway, well, then the package is a little bit smaller. There are fewer annexes to be prepared, and the funding request narrative itself is going to be shorter. What stays the same? Countries will still have to make sure that their priorities, that their funding requests are fully aligned to their national strategic plans. But in this particular case, we're asking, in case a country is preparing different funding requests for different diseases, to have them submitted all within the same window and possibly as one application. What does this mean for communities and for key populations representatives, for instance, is that there will be a compressed timeline for the preparation of the funding requests, which can mean that a lot of meetings will be taking place at the same times. People will need to be able to be sitting in all these places, and key population representatives will have to find ways to delegate to one another to make sure that we can all be there in those rooms when decisions are being taken. So really, recommendation is to know well the deadlines that are going to be communicated in your countries. Make sure that you find ways to be all united as key populations representatives to come up with a number of priorities that are known by everyone, and that if we increase the chances of making sure that, if we repeat them all at the same time, if we all are consistent in our messaging, then those priorities have a better chance of being integrated. So yeah, just maybe recommendations around this planning ahead and being prepared, because the time won't be as much as we're used to. If we go to the next slide, there's another new thing in terms of the submission pathways. So you have at the bottom the funding request classic submission pathway, which is exactly as it used to be in GC7. So we prepare the funding request, TRP reviews it, and then we go into this grant making phase in which the detailed budget, the targets, the performance framework are discussed over a number of months. Well, this is one, and it can stay, but there is also the possibility for CCMs and countries to choose what we called a grant-ready submission pathway. What does this imply? This implies that at the moment of submitting the funding request, countries will already identify the PR, the principal recipients for these grants, which have to be the same that we had in GC7. What does this mean is that the PR will already work at the time of funding request submission in developing a grant-ready detailed budget and a grant-ready performance framework. This means that there won't necessarily be a very long grant-making phase, or very minimal changes will be done at that stage. So again, if your country is choosing to go with the grant-ready type of application, it's really, really even more critical that you engage in those conversations and those discussions during the funding request preparation. If we go to the next slide, I'll say a few things about the modular framework and what are the key changes. So the modular framework is mostly exactly very similar to what we had in GC7. We, though, made some changes mainly to streamline it and shorten it because the document was very, very long. When it comes to key populations, what are the key changes? Well, now we have basically only one prevention module with all the different interventions. And for key populations, they're going to be all grouped together under that one intervention. So before you had a different prevention module for each key populations, now you have one prevention module with all the different interventions that we had before yet they're going to be grouped by all key populations. This is just to streamline the document. It does not mean that you can't plan or prepare an application specifically for MSM prevention or have a program for sex worker prevention. Yes, you can and you should do that. It's just that at our level, it will be aggregated. Another difference is that we no longer have a human rights interventions under the HIV prevention modules. Now, all human rights interventions and gender interventions have been grouped and moved under RSSH. This is just done again to streamline and to give more of a one place where all human rights and gender interventions could sit rather than across different disease areas. Again, this does not mean that you have to pay for gender and human rights interventions with the RSSH money that is allocated to that particular area. You can't totally, decide to pay for HIV-related human rights interventions with the HIV funding envelope. It's just a matter of where it sits in the modular framework. And for CSS interventions, for community-led monitoring, for all interventions that strengthen key population-led organizations, that as before stays under CSS, which again sits under RSSH. So these are the key changes in the modular framework. As I said, nothing very different. It's just a matter of streamlining this particular case. If we go to the next slide, I'll move a bit to what are some of the KP, the priorities when it comes to key populations program. And here you see those three big words at the top, optimizing, adapting, and integrating key populations programs. What does this mean? Well, it still means that we want our program for key populations to be based on scientific evidence, to be based on HIV incidence data, but obviously we have to start thinking also about the resources that we have, which is, one of the key things, the key changes that have occurred since GC7. So what does this mean in practice, having less money? Do we need to stop doing what we were doing? Not necessarily. It means that we still want service delivery approaches to be based on trust, to make sure that key populations trust whoever is providing and offering them the services. Yet it might mean that we have to look at at ways of doing things differently. For instance, you might have a program that employs peer education or peer educators to do a lot of the work. What we're saying is not to stop doing peer education, but maybe to look into the program, look where efficiencies can be made, look at the performance of peer educators to understand those who maybe are not right in that particular position. We're also saying, for instance, consider new service delivery approaches, for instance, pharmacies, for instance, online approaches where they make sense. And the last thing we're trying to say as well is that consider integration key populations programs into primary healthcare when and where it is possible, when an assessment done jointly with community representatives is telling us that integrating this particular service in this particular place can make sense. But I'll speak to that in a second. If we go to the next slide, I'll discuss a bit more this idea around integrating key populations program. So it really is important when we consider integration to avoid as much as possible a rushed and an unplanned integration of key populations programs into primary healthcare. We want to make sure that communities are engaged in the decisions that are taken around transition and that we allow for time for this to take place. Important, for instance, as well, is to avoid at all costs that we see the availability of services for key populations reducing as a result of integration. We want to make sure that people will still have access to services wherever they are offered. Now, if this means integration in public health facilities, that definitely is something that we can and should consider. But for instance, not for those populations that are very unlikely to access health facilities, particularly if in those health facilities we are still identifying many stigmatizing practices. So it's really important to also consider the type of service delivery points that exist at the community and understand if this one is something that needs to be preserved and protected, even in an integration scenario. And I'm thinking specifically of services that are very specialized, like, for instance, harm reduction ones. Think, for instance, of a needle and syringe program that is working really well at the community level. Does it make sense to integrate it entirely, to stop it at the community level, to only offer it within health facility? It could be in some countries, but probably in others it might not be the case, or we need to allow for a longer transition of this service into a public health facility one. So it's really important to be able to, as I said, plan properly and give it time. Another thing, another big risk that we're seeing in terms of key populations programming being integrated into public health facilities is the risk for breaches in confidentialities or anonymity. You know, people wanting to have their anonymity preserved, and this not being possible if you want to access a particular service. So also this is an aspect that needs to be carefully considered and evaluated and mitigated if possible as you implement an integration plan for your key populations program. And I'm going to conclude with my last slide, which is really around collection of additional tools that can give you really a feel of what it is going to be planning for key populations program in the future. A lot of these tools have been prepared directly by key population networks. Some others have been developed by other groups in collaboration with CRG. All the links are there. You can see them. Not all are published yet. If you get in touch with CRG, we can definitely point you to the latest draft. And thank you. I'll stop here.
Thank you, Matteo. That was really critical information for everybody involved in the planning, the writing, and advocating around GC8 for key populations. And it's really clear that there are a lot of differences to GC7, not just the application form, but also the direction. So two things that really stood out to me was around the preparation, the need for preparation rather, and having a unified voice in advocating for priorities, but also the need for really careful planning for differentiated approaches and how integration can and should be done. So a lot to think about. If you do, any of the people online, if you have questions for Matteo or any of our other speakers, please use the Q&A function and type your questions in, because we will have time for a Q&A later. Our next speaker is Dr. Anton Mozalevskis, who is a technical expert on key populations at the WHO Global HIV Tuberculosis, Hepatitis, and STIs Department, based in Geneva, Switzerland. His background includes 7 years of clinical experience, over 10 years in public health, policy, and research, and extensive experience engaging with human rights and health at both national and international levels. Over to you, Anton.
Thank you, Helen Marie. So good morning and good afternoon, everyone. I'm presenting on behalf of WHO and also UNAIDS and JPC. And I will walk through some main WHO and UNAIDS guidance, and more importantly, we'll focus on how these documents can be used in planning and implementation. Next slide, please. So this slide points to WHO consolidated guidelines for key populations. This is really a core reference document which outlines the comprehensive package of services. So throughout this presentation, we will take this document as a baseline standard for program design. Next slide. So in the guidelines, WHO proposes or groups interventions into 4 categories. First are enabling interventions, things like reducing stigma, discrimination, removing punitive laws, and also addressing violence towards key populations. Second, these are essential health interventions, which these are, for example, PrEP, condoms, and harm reduction. So these are essential and have direct impact on the HIV incidence and prevalence. The third group is so-called essential for broader impact. So they don't directly, not necessarily directly impact HIV outcomes, but they improve health and also they from the perspective of person-centered care. And finally, there are supportive interventions like communication and demand generation. So I think the key message here is that the impact doesn't come from isolated interventions. It comes from combining those different elements. Next slide, please. So these are the supporting documents. So that we have policy briefs which outline and explain the comprehensive package for each of the 5 key populations. You can find them online. Yeah, so basically they are published on WHO webpage. Next slide, please. And this slide, it's a kind of a checklist, or like in one slide, we try to list the comprehensive package for 5 different key populations, including enabling interventions, without which the uptake will remain limited. Core interventions for prevention, like condoms, PrEP, PEP, or harm reduction. Of course, testing and treatment services. WHO, we see that the testing and treatment is actually a part of prevention. We cannot really see prevention isolated from other services. So I think the takeaway message here is that programs need to deliver a complete package, not just selected interventions. Next slide. A few words about some new guidance coming from WHO last year and this year. We have updated our guidance on harm reduction specifically, and we published 2 new documents. One is the guidance on opioid agonist maintenance treatment, or medically assisted treatments, called differently in different countries. And the second one is the operational guide on needle and syringe programs. There are links where you can find those documents, but also links to the launch webinars with excellent country presentations, which we conducted together with the Médecins du Monde and other partners. So next slide. Just a few words about the OAMT guidance. So that's a document which helps to mitigate the disruptions of OAMT. As we know, the year 2025 was particularly challenging, with a lot of risk of stopping services. And as we know, the OAMT, or medically assisted treatment, or opioid agonist maintenance treatment, is essential and life-saving intervention. That interruption in treatment can cause serious and even fatal consequences. So the programs should ensure continuity of care, especially where these services are already available. These are one of those services that have to be maintained as a first priority. So this document also helps to plan ahead for disruptions, especially in emergencies, and also this is really about protecting both health outcomes and saving lives. So next slide. So the second document is the NSP, or Needle and Syringe Program Implementation Guide. And it's kind of an update from a very old publication, not very old, but from 2007, which has a lot of new information, including on, there is also an annex, so-called quantification tool, which you can find in this document. It's also an online document that you can download and use for quantification and for planning and for developing your proposals. So this document, like in general, it has 5 modules, including assessment and planning, like preparing and conducting the population size estimates and assessing the needs. The second module is about implementation modules, which includes all different kind of models where you can provide harm reduction services. The third module is about adding comprehensive services, or about integration, or about making the services as comprehensive as possible. The fourth module is about monitoring, and the fifth module is about scaling up. So basically, the idea is that the pilot projects are good, but to make sure that the program makes a real impact, you have to scale up on a national level. So I think there is a particular emphasis on community-led approaches and also human rights and equity principles. So I think the key takeaway here is that peer-led needle syringe programs are essential for trust, reach, and sustainability. Next slide. Also, last year, WHO published a guidance for member states how to prioritize or sustain priority services for HIV in changing funding landscapes. And here in these slides, we are presenting the prevention interventions, and you can see that tier one or so-called essential interventions that have to be prioritized in all settings include condoms, PEP, prevention of vertical transmission, and also harm reduction, especially in settings where these services already exist. So, as already mentioned before, interrupting harm reduction services can have really immediate impact and consequences. Next slide. So now going a little bit to wider Global Prevention Coalition, there is a special resource hub which organizes all available guidance, planning and management tools and analytical tools from UNAIDS, from WHO, and also from other partners. And this document can really help for setting targets and program monitoring and for preparing the funding proposals for the GC8. Next slide. Yes, that's again for this prevention hub. As you see, there is like a separate section on prevention, and there are a number of tools. You can explore the webpage and find a lot of useful tools. Next slide. So I think here in next slide, there's a quick reminder about the Global AIDS Strategy 2026-2031. And the headline targets is like 90% people in need should be using or should have access to prevention options. But there are also important targets around community-led service delivery. There's also reducing stigma and discrimination and integrating in financing. So prevention programming in GC8 needs to align with this broader vision of the Global AIDS Strategy. Next slide. Another guidance just published by the GPC is the Global Access Framework for HIV prevention that introduces a more structured approach. So it's emphasized the people-centered programming, better data and decision-making, and systemic prioritization. It also provides tools to estimate the needs and monitor and track progress. Next slide. The key concept from this framework is the 5P of prioritization. That means place, people, places, packages, platforms, and prices. So the idea is to ensure that prioritization is holistic and it's not just based on one of those 5 dimensions. So we're not only asking what intervention needs to be prioritized, but also for whom, where, how, and at what cost. Next slide, please. Yeah, the framework also includes some practical planning tools, for example, templates for prevention planning, tables for setting targets and milestones. So all this can help to translate strategy into operational plans for GC8 and beyond. Next slide. Again, another important document is the updated trusted platform access. So now we call it planning and managing of HIV programs with key populations. And the idea is simple, that people use services which they trust. So these platforms can include community-led services, peer outreach, but also key population-friendly clinics and like more general health facilities, which are key population-friendly, which have some criteria, including measures to reduce stigma and discrimination to make it accessible and acceptable for key populations. So this document has two parts. One is about understanding the trusted access platforms, the key elements, planning, and also guidance for cost-based benchmarking and roles and responsibilities, how these platforms work. And the second part is about planning and managing those access platforms to achieve scale and scale an impact. Next slide. So again, from this document, there is, I mean, you can see that these services need to be adapted to context, to available resources, epidemiology, legal and policy environments, preferences of key populations in every settings, and also, as I mentioned, available resources. So there is no one size fits all, and then program design must be context specific. Maybe we can go to the next slide. Here, there's one slide with some additional guidance from South to South learning networks. You can also find as a part of the GPC database of useful guidance. So there is implementation guide for young women who sell sex, which focuses on addressing structural, behavioral, and biomedical risks and provide guidance on outreach, service delivery, and community engagement. There is also an analytical framework on prevention cascades that helps to identify gaps in service uptake and measure coverage and continuity and prioritize resources to reduce HIV infection at the population level. There's also a peer education evidence synthesis report accessible, and also one specific document on stigma among MSM produced by SSLN. Next slide. A few documents from UNAIDS on community-led response tools, including the case studies from Eastern and Southern Africa on CLM in the context of HIV and beyond. And then also another report on community-led monitoring in action. So these tools include values of community-led monitorings in HIV and health services, creating enabling environment, strengthening community systems. There are case studies of HIV, CLM, service delivery in Eastern and Southern Africa, already mentioned, and some explained service delivery that reach and provide impact beyond HIV services. Next slide. Finally, going to the global partnership to eliminate all kinds of HIV-related stigma and discrimination, also has developed a number of practical guidance to address stigma and discrimination in different settings. There's a practical guide, there is a checklists and monitoring guidance. There are also some documents from partners such as IAS and Beyond Stigma, which is a project which addresses internalized HIV stigma. And also I have to mention there is also a technical brief from WHO on addressing stigma and discrimination in healthcare settings specifically. You will have the links to all those documents. So maybe next slide. Yeah, this just very briefly about upcoming checklist on HIV prevention that will be published on the GPC website, that will have a specific checklist on HIV prevention for the Global Fund applications. So, I mean, to conclude, I think I need to say that there is a lot of guidance and tools available, freely available on WHO and GPC and UNAIDS websites. And the key challenge is not to develop more guidance, but to ensure that these documents use strategically and coherently. I think I will stop here. Thank you very much for your attention, and I'll try to answer if there are any questions. Thank you. Over.
Thank you, Anton. That was an absolutely epic journey through the relevant guidance and tools from WHO, from UNAIDS, GPC, SSLN, and other partners. And some of this guidance and tools is also very new. It might be the first time some people on this webinar are seeing it. Could you move to the next slide, please? Okay, wonderful. And thank you, just one more thing. Thank you, Anton's, also for highlighting stigma and discrimination. We know that this is really such a major issue with accessing services, with feeling comfortable with services, with accessibility and acceptability. And I think it isn't appreciated enough how much this impacts how service delivery has to happen. So I think it was really good that this was highlighted. Because we know that you will want to look at all of this again, just a reminder that the slides will be available on the SSLN website shortly after this webinar. And of course, the webinar is being recorded, so will be published. So right now, I want you to, if you can, get out your phone to engage in a little Mentimeter. We're also pasting the link for the Mentimeter in the chat so that you can participate. So just taking a moment, if like me, you're scanning. And so the question for our Mentimeter, because we really want to hear from you, is what information about GC8 would best prepare you to advocate for the inclusion and prioritization of key population programs in the country proposal? Sorry, the end of that question got cut off a little bit. So we really want to hear from you. What is the information that would best prepare you? We've got, yep, please feel free to send a thumbs up if you're in. You can let us know that you're here. We've got 21 responses so far. 25. Okay, so we're starting to see the responses come in. We've got one response about direction on available resources to support consultations. Absolutely. So hopefully we've provided some of those resources to you through this webinar. There are a lot more. National priorities aligned with communities and vice versa. Issues on removing legal barriers. Yes. So beyond stigma and discrimination, legal barriers are a huge issue for accessing, using, feeling comfortable with HIV prevention services and products as well. HIV Global Fund notes, perhaps Matteo can drop some links again to all of the Global Fund application supporting materials. And certainly that will be sent to everybody who's registered. So you'll get the slides or the link to the slides. Implementation techniques for countries, available tools and resources. Again, hoping that we will get that this has been helpful for you. We also have a request for best practices from Global South countries, and our next session in this webinar, so just after this Mentimeter, we will be hearing from experiences from community and from government in 3 countries. So stay tuned. Available resources, national dialogues, addressing structural barriers and implementation tools. And how community-led interventions will still be maintained, particularly prevention around needles and syringe, OAT, and naloxone and community-led responses. So actually, Matteo, can you please note that question, because I think we will get you to respond to that when we come to the Q&A. How to maintain community-led interventions around harm reduction.
Yeah, for sure.
Okay, so we're coming to the end. Thank you to everybody who has responded. Please continue to let us know. And my colleagues at SSLN will have a look through, and if there are questions that we can also answer during the Q&A, we'll grab those. So thank you for responding to the Mentimeter. During the next part of our agenda, you will hear from a panel of three amazing people and about their experiences in country with Global Fund proposals, particularly around HIV prevention. Our first speaker is Bella Aubrey, and Bella is a transgender youth and human rights advocate who serves as the chair of the Global Fund Youth Council and national coordinator of Inti Muda Indonesia, a youth-led network focused on advancing rights and health of young key populations and young people living with HIV. Her primary work involves strengthening these youth-led movements and ensuring young people are meaningfully included in national and global decision-making. Over to you, Bella. We're so pleased to have you here.
Yes, thank you, Heather. I didn't have any presentation with me, so I just want to talk and share my experience in the GC7. It's been really tough processes when I joined in G7 because I'm a representing of a youth. I was really young at that time, but I demanding to the CCM and also the country to engage in the GC7. And what I've learned in GC7 is like the community advocacy is really matter because like key population are central of the HIV response, and we are often under represented in the decision making. And what I also learned is as a community, we need to start with data, not assumptions. So it's really important for us to engage in the global fund processes in the grant cycle to also knowing and starting with the data. Like Indonesia has clear targets, national target aligned with the 995 goals, and at the same time there is gaps remain in ensuring that services are accessible and used by key population. And what I also highlight that in the GC7, we often use the community-led monitoring data as the basis for the intervention that we make, especially for the prevention. In Indonesia, we also have push the condom and PrEP access for the young people because I work for the young key population. And it's kind of difficult because there is a lot of barrier, especially like a systematical barrier, like law and also regulation that not allowing showing condom and like delivering condom to youth and adolescents, and it's kind of difficult for us to do some prevention. And we try to change the law, and we are a lot of talking with the Minister of Health how we could handle this. And yeah, we currently also have the penal code in 2026 when it comes to like delivering condom to the youth, and it's kind of will be challenging and criminalization for the activists and also us in a outreach worker in the global fund context. So what we do in the GC7, we are not only addressing in the supply side because we know that sometimes the system, the healthcare services is still discriminated, but also in the demand creation. So most of the intervention in the GC7 that we push is also demand creation for the community, because especially for the prevention, Indonesia still needs to do more demand creation because some of them are not knowing the prevention tools. So we need to do that. And that needs to be led by community. And that's what we do in GC7. And we still need to do that in the GC8. And yeah, it's still kind of really difficult to navigate all this obstacle. And when we see in the GC8, we have also a different kind of information when it comes to like developing the proposal. The community rights and gender are under the RSSH module. So we need to make sure that all this kind of work regarding to handle and tackling the regulation is also addressed in the RSSH modular. And also, I want to highlight that in the GC7 processes, we were able to successfully advocate for the inclusion of a young people population in the country proposal. So I engaged fully in the making of proposal, and we are also putting the concept note of the young people population intervention as annexes in the proposal, and this was also supported by UNINs, and also most of we make this concept wise based on community insight and also lived experience. That's important, and also alignment with the national priorities, and also clear articulation of unmet needs. So we need to have a really clear intervention, and also the challenge about this engagement that I see is. Sometimes when it's come to the grant cycle in the Global Fund, the community often more focused in the first stage, which is the making of proposals. So all committee are focusing on that. But then in the next step, which is the implementation, the grant making and implementation, sometimes the community are still left to like monitor it. So that's what happened in G7. What I've learned is we are only engaged in the first stage, but we don't really engage in the next step. So we lost how about the implementation that happened in the GC7. So what we want to do in the GC8 is we really need to make sure that communities are engaged in all stage of processes in the grant cycle. So not only in the first stage on a making proposal, that's the most important thing, but also we need to make sure that those recommendations from community are implemented in the whole cycle. And that's a really challenging also for us, but that's a key lesson learned that I learned for the GC8. And since my country in Indonesia is reaching out to submit the proposal in the first window, which on the first week of June, 8 June, and it's kind of really tough to keep up with the time. And I really hope if you guys, community that from the country who submit in the second window or third window, you can have time to prepare by now to start with data, to start making intervention, to engage, to like making the community priorities, because it's really important, because like the country that submit in the first window, it's kind of difficult for us to really engage in the processes, because sometimes like we are informed late of the country dialogue process of the discussion that happened in the CCM, because like they also like try to achieve the time, because like we need to submit this on June, so we need to make it fast, and sometimes community are not engaged in those kind of things. So for the audience that the country submit in the window second and third, I hope you could try from now to discuss with community to do a consolidate about how you could prioritize the community intervention, especially for the prevention, because
Sorry,
you
Bella.
still have time. Yep. That's all from Heather. Thank you.
Thank you so much, Bella. It was really powerful to hear from you about your experience and the challenges in Indonesia, and how you and colleagues in Indonesia are overcoming them. And I especially liked your advice about making sure that CLOs are engaged throughout the grant cycle, not just in that first part of it. Thank you so much. And we will hear from Bella again in the panel discussion. So if you have more questions about her experiences and her expertise on this, please include it in the Q&A chat. Our next speaker is Grace Camus, and Grace holds a bachelor degree of sociology and political science from the Catholic University of Eastern Africa. She identifies as a female sex worker and has worked in the HIV field in relation to key populations for 8 years. She has previously worked as a bar hostess at Bar Hostess Empowerment Program as program officer and as a consultant for the global network of sex work projects. Her passion has been working with sex workers on issues of HIV prevention, human rights, and movement building. And she also worked as the national coordinator of the Kenya Key Population Consortium. She currently is the Africa Sex Workers Alliance regional coordinator in Nairobi, and was recently appointed as a member of the Feminist Opportunity Now Africa Regional Coordination Committee, and has a seat at the Mama Cash Supervisor Board, as well as just recently President-elect of the Global Network of Sex Workers Project. That's a lot of things, and so we're really pleased to hear from you now. Grace, over to you.
Okay, thank you so much, and thank you for the introduction. And I'll go straight to the discussion. So I want to say that we've come from very far from the engagement with Global Fund writing. And I want to say that previously, in the previous years, when we talk about GC Cycle 6, Cycle 7, those days were difficult for sex workers to engage, but we've seen a lot of change. And those days, I remember we were even struggling with issues of data, issues of IBBS, size estimates were not right. We couldn't even understand how to write a global fund processes. We didn't have a seat in the CCM, but that has changed, and that has really improved from that time. We now see a lot of sex workers from different countries sitting at the Kenya coordinating mechanism. We see sex workers in many countries sitting as a CCM representative and representing sex workers at CCM. And that has really improved the engagement of sex workers because in many countries where we work as the African Sex Workers Alliance, we continue to see sex workers having constituency meetings whereby key population will sit down, have their constituency feedback meetings, and have a discussion on how the Global Fund processes going on, and what are the issues that sex workers continue to face in the different areas of Global Fund engagement. But as we move on, we continue to see that there is no deliberate prioritization of funding to, for example, key population, like ring fencing money for key population programs. We see that money for key population is there, but money goes, in some countries, money don't go to key population-led programs, but they are implemented by civil society who work with key population. And for Global Fund, continue to push for community-led programs. We know different countries have different processes, but these are things that our sex workers program and our sex workers, we continue to push for sex workers-led programs to implement their own programs, because we know it's more cost effective when sex workers lead their programs, but there are countries we continue to struggle with pushing for sex worker-led organization and civil societies to do their programs. And in these countries, we also continue to see whereby sex workers also don't engage effectively, because some of the countries will start in the writing, but they don't follow up the process to the last cycle. You'll find that there are countries where sex workers will do the writing, but they'll not go to the funds allocation meetings. They will not go to meetings whereby sex workers need to know how much goes to key population. You just give the priorities of your constituency, but you don't follow up. But this is due to some countries we see that there is lack of information, and this is attributed to many causes. And at the current moment we are at where there is limited funding, we see that most of the sex worker programs and most of the sex workers organizations are closing down due to limited funding, and most of the organizations now don't have money, and so most of the sex workers are closing down. So we are seeing that even with this current Global Fund writing cycle, which is very clear on how things are going, we are seeing that there's a lot of conversation about integration. And as sex workers, we are coming up with our bare minimum and our asks that we are going to share with the countries that we work in, so that we have our asks as sex workers, what we need. But as I said, the issue of the challenges of funding is the most is the challenge now, because most of the sex workers organizations don't have resources even to go to those writing processes. And so we are looking, and as Matteo had spoken, that we need to be we need to, this is the time that we need to be together. It's the time that we need to talk in one voice. But now we are seeing because the processes are being led by the government, there's a lot of, when you go to these conversations, you are told it's G2G, it's G2G conversations. And we are seeing whereby issues like criminalization of sex workers and criminalization of key population being one of the biggest challenge that has been there since the Global Fund processes, is now one of the critical things as sex workers we are being faced with when we are talking about integration. And when we talk about like prioritization of prevention, HIV prevention services, we are left at the mercies of the government, for the government to decide which prevention services are more critical to the government, and that government feel they are more cost effective to them, but it's not what the community is saying. But we know that community should be take lead. Community should be at the center. But as I said, different countries have different processes, and different countries are taking different shapes and sizes on how they do their consultation. And so for us, as key population, as sex workers, we feel sometimes, and we feel that we are being left out in conversations. And when you go to those conversations, you feel that the government, because the government is the one that is leading the conversation, we feel that sometimes we are being sidelined, and our issues are not taken into consideration. There are many things that are on the table when you talk about integration when it comes to GC8. There are many things that communities don't want to drop, and the government also don't want to negotiate. There are things that the government are saying that these are the bare minimums that we want to, but the communities feel that those are not the bare minimums. So these negotiations at this point are very difficult for us. And we hope that we continue to have this discussion so that when we are writing the GC8 and when we have our priorities that we have come together as sex workers and as key population, and the government agrees. But as I said also, different countries have different ways of doing things. So as sex workers, we are coming up with our bare minimums that we can give the government, but the conversations are not easy. And so also when we talk about GC8, one of the most critical things is issues about legal support, the structural barriers. We are seeing governments giving priorities to biomedical issues, but issues on structural barriers are issues that the government is shy to talking to, like for example, legal support for legal support for sex workers. When a sex worker is arrested, is the government or for example, the healthcare facility, we are saying about integration of these healthcare facilities, this healthcare in primary healthcare facilities, is the government ready to employ a lawyer when I go to this clinic and I have I need, for example, PrEP, and I have been raped, and I need a legal support? Is this something the government will pursue? So, but we continue, and we know as sex workers, we should take the center stage, and we are really doing advocacy with the governments to ensure that our voices and our priorities, and letting the government know what our priorities are, and making sure that the government take on board what priorities we as sex workers need. So thank you so much.
Grace, it is amazing, as you outlined, how far we've come, but how important that continued engagement remains, and also the tension between community and government priorities. I also really appreciated that you outlined how much criminalization across many countries impacts the engagement with the services, but also with just engaging in the processes, in the conversations, and with the partners that you need to engage with. I think that this was really powerful. Our next speaker and final speaker on the panel before we get to the Q&A, so please drop your questions in the Q&A, is Dr. Barbara Mombo. Barbara is a senior clinician and global health leader with over 15 years of experience in HIV prevention, care, and health system strengthening. She serves as the head of the HIV Prevention at NASCOP in the Ministry of Health Kenya, where she leads the national programs on PrEP, triple elimination, and key and vulnerable populations with a focus on health equity, youth engagement, and resilient integrated health systems. Not a small job. Over to you, Barbara.
Thank you very much, Heather, for the kind introduction, and greetings, everyone. So today I'm speaking from the Ministry of Health, Kenya, and I want to share our perspective on how we engaged the key population community-led organizations in the GC7 process, what we learned and what we can improve as we prepare for the GC8. I want to keep this very practical because for us, the main lesson is simple. Community engagement should not happen at the end of the process. It must start early, it must be supported, and it must help shape real decisions. Next slide. So how did the Ministry of Health ensure that key population CLOs were engaged? For the first thing we did as government is we brought the CLOs into the process pretty early, before the writing of the funding had fully started. The key population CLOs participated in our technical working groups, where we looked at what had been achieved under the GC6, what gaps were still there, and what needs had not yet been met. This was important because the communities were not coming in after everything had already been decided. They were part of identifying the gaps from the beginning. The KP CLOs were also included in the GC7 core team, the secretariat team, and the proposal writing teams. This helped to make sure that the community voices were not only heard in consultation meetings, but they were also present inside the actual writing process. Next slide. Another important point is that the CLOs were not just invited to attend meetings. They also acted as information providers. They brought real information from the community, what services were working, where people were struggling, where access was difficult, and what needed to be strengthened. There was regular update meeting with the CLOs so that the organizations could receive current information, concept note, timelines, and guidance on which meetings to attend. So CLOs were also able to give feedback on which interventions should be implemented better by the community-led organizations and which ones were better handled by principal recipients or other partners. So the aim was to move from just consultation to more meaningful participation in planning and decision-making. Next slide. Of course, the process was not perfect. There were challenges. The first challenge that we saw was that there was no specific funding to support CLOs during the writing process. Many organizations had to look for their own support to participate. This is something we need to improve, definitely, because participation has a cost. People need transport, people need to create time, and there's also preparation. And sometimes there's also need for accommodation for the community members. The other challenge that we saw was the accessibility of meeting venues. Some meetings were held in places that were far and difficult to reach, especially for community representatives who did not have private transport. At one point, one of our venues became a big concern, and it was even boycotted for the writing. And this was an important lesson for us. It is not enough to invite people. The meeting must also be reachable. Another challenge was data, as has been brought up previously. So during GC7, we did not have all the updated KP numbers that we needed for proper planning and costing. But now we are lucky because as we prepare for GC8, we are in a much better position. We already have our BBS data of 2024, which can help us plan better and advocate with stronger evidence. There were also some technical challenges that had been reported. Some of the consultants that were hired to support the process did not fully understand the KP modules. So the CLOs had to explain and translate what the modules meant in practice. That was not easy, but it also helped strengthen community capacity. Next slide. So for GC8, the advice is very practical. First, we need a clear roadmap. Everyone involved should know the timelines, the key meetings, who the writing teams are, the points where the decisions should be made. This roadmap should be shared early enough with all of the CLOs involved. Second, the CLOs should be supported to participate. We should not just say communities are invited. We must make sure that they're able to attend, prepare, consult their members in time, and give meaningful input. Third, the venues have to be accessible. We need to choose meeting places that community representatives can reach, not only places that are convenient for people with private means. And fourth, our working groups must be well managed. Team leads should be clear, roles should be clear, deadlines should be clear, and this helps avoid confusion and make sure the community input is not lost. Fifth, the CLOs have to, if we have one shared folder where all important documents are kept, that's the concept notes, the meetings, the data drafts, and the everything, the feedback. This helps to make sure everyone stays informed. And finally, we need to document the process properly. What was discussed? What was agreed? What was included and what was not included? That is also important to document. This will help the accountability and future Global Fund applications. So next slide. So allow me to close with this message. Meaningful KP engagement is not just about inviting the communities to the meetings. It is about bringing the communities on board early enough, supporting their participation, listening to their evidence, and allowing them to shape their decisions. From the Ministry of Health side, our role is to keep the process transparent, inclusive, and practical. From the community side, the role is also very important. You have to come organized, come with clear priorities, which are already aligned, come with evidence, and speak with one strong voice. If we do this well in GC8, then the process will not only be about writing a funding request, it will be about building a stronger and more community-led HIV response for the country. And with this, I come to the end of my submission. Thank you very much, Heather.
Much, Barbara, for outlining an example that I think is a really effective approach that could be applicable for other governments and other countries to take, and one that CLOs could advocate for if you thought it was something that you liked. I especially liked your final slide that meaningful engagement is not just invitation. It is early, supported, accessible, and evidence-driven participation. So that was, for me, incredibly powerful. I would like to invite all of our speakers now to please turn on your cameras, because we will have just about 15 minutes now for an opportunity for a panel discussion. And we have had some great questions that have come through in the Q&A. Please, if you are online, you have a question for any of our speakers, please put it in the Q&A so that we can get to it. So I want to start with Matteo. There was one question that came up in the Mentimeter that I thought was actually a really important one. And I would also welcome Barbara, Grace, or any of our speakers if you have any comments about this. But can you tell us a bit about prioritizing and maintaining community-led harm reduction services for people who use and inject drugs? We know that this is quite politically contentious. So what advice do you have about this?
Thank you so much, Heather Marie, and thank you so much for the great question. And I think this is a very, very important topic to discuss. I tried to touch on it as I was talking about, talking through the slide on integrating key populations programs into wider primary healthcare. And I noted that specifically one of the big risks that there is when we look at integration is specifically the one of losing specialized services that exist and are very successful also delivered at the community level. And this is a clear example of that are, for instance, needle and syringe programs that are implemented mainly by key population-led organizations or community-based organizations. Now, I do think that when we think through integration, we have to be aware that there are certain services that really, for which integration might not be the best course of action, or where if we are thinking of integration, we really need to think through the details of what, within that intervention can be integrated and what are the aspects instead that cannot be integrated. So to me, that's one thing. And I think it's important that as communities and key population representatives are discussing integration plans, they make it clear, what is the value of these interventions and demand that planners allow for a transition timelines that take into account the specific risk of losing the services at the community level. Now, what can we offer to them? What can we offer to the policymaker? My view is, for instance, that, as it applies to everything else, all the other service delivery approaches, we have to be ready to adapt what we are doing. We have to be mindful of a situation where our programs need to become more sustainable. In a way, will have to cost less. That's the reality. We're struggling with a reduced amount of money. So what are, when we look at the program we're implementing, where are the possible savings that we can make? How can it be adapted or optimized so that it costs less in a way? Can we identify areas where we might not need as many community distributors? Can we identify places, for instance, where we can substitute peer educator distributing syringes with another form of community-based distribution of an NSP? I'm thinking, for instance, pharmacies, community-based pharmacies in certain places have worked as community-based distribution points, non-stigmatizing, where injecting drug users could access syringes themselves. So I think it's really it's also a time for us to challenge ourselves in our own way of doing things, seeing if we can do them in a different way, in ways that is optimized, still reaching the same results, but maybe costing less and maybe leveraging new technologies or new service delivery models. But I stay with the key message that there are certain services that need to be preserved at the community level. We can't necessarily think that everything can be integrated into health facilities right away, for instance, at least. Thank you. Hope that addresses a bit the question, Heather.
Thank you, Matteo. I think that that's a really important point to emphasize, that this isn't wholesale. We just put everything into facilities, into primary care. It is that there is a differentiated approach and it needs to make sense in the context. We've had a few other questions. There was one that I know that you already answered a little bit in the chat, Matteo, but perhaps others would like to weigh in on, Barbara, and others. And this question came from Jacqueline Pinar. Would you recommend a Global Fund country mapping exercise to determine NGO coverage? Is this something perhaps you've done in Kenya, Barbara, that you could comment on? So Jacqueline says this could help in ensuring localized upskilling and keeping these NGOs relevant and visible, and prepare for them for Global Fund funding. And also, Grace and Barbara, if you would like to also weigh in on this, please. And I've just, for our hosts and panelists, I've just copied the question in the chat so that they can also see it. So Barbara, if you would like to unmute.
Oh, sorry. I think I was speaking with my mute still on. So great. So about a targeted mapping exercise, that's a great question, and that is something that we're embarking to do. Even in Kenya, we are looking to understand where the resources already lie for our prevention programs, to understand where the services already exist and what the real gaps actually are. And it is going to be important in our prioritization of what we're going to use with the funds that are being availed through Global Fund. However, even when we're trying to do our mapping, we have to make sure it does not really delay what the process is. We're already on the nose of writing, and we cannot wait for perfect data in order to be able to commence with writing. So any mapping exercise should complement what is already known, and not to sort of hold back the process or make us restart our process. So that is what I will think as a response to this question. Over.
Thank you. That was great. Bella, or I'm sorry, I can't see everybody on the screen, but Bella or Grace, are you able to, or would you like to weigh in on this question?
Yeah, sure. And I have unstable network, and I hope people are hearing me.
We
I
are.
concur what Dr. Barbara said. It is important to know who's doing what and where. Yes, it's good to know who's doing what and where there is coverage of services and where there is no coverage of services, and how do we ensure that where there's no coverage of service, that people who need services most get them where it's not available, but it should not delay the process, because we need resources as soon as possible, because there are no resources. But it is important, like looking at community led dropping centers are in and things that don't need to.
Amazing. Absolutely. Thank you for that. Bella, did you have something that you would like to add to this?
This is about a country mapping, or
Sorry. So this is
this
about the
is
community mapping, yes.
yes. So I think yeah, this is also really important, and especially when it comes to like again representation. Sometimes like the youth and young people population like also needs to be considered in a room, and also like especially like to um keep all the issues that are related. And sometimes when it comes to like children and also young people is not sometimes being considered in the of funding requests. And especially like when it comes to the very tight timeline, the NG or the community are not having time to having some like meeting together and sit together and decide this is our priorities. So all it's only happen in the country dialogue. There is no community consultation before the country dialogue. So this like country mapping and also like the community and NGO discussion and also sit together is also really important for the GC8 preparation. Yeah.
No, that I think that that makes a lot of sense, and I think will resonate with a lot of community groups. So a question for you, Bella, now while you're here, and also for Grace, you both mentioned that a challenge that key population community-led organizations have is that you're involved in those early stages in the priority setting, the consultations, but not necessarily all stages of the grant cycle. And this really does lead to poorer implementation of programs and data collection, things like that. So what advice do you have for community-led organizations, but also for governments and other partners to support key population-led organizations to be involved throughout the process? Just
Yeah.
maybe
So
a sentence or two. Thanks.
yes. So I would say like in the early stage, all the community are involved and engaged in proposal and development. But again, when implementation, we are lost. But again, there is a place that the committee could also intervene and like being having a oversight committee and also having monitoring roles in CCM, which is really important for community to also engage in CCM and a technical working group. So I would really recommend for the community to also engage in those spaces, because in that spaces you could really monitor all the information within the PR, the principal recipient, so you could know how the update. But again, to be in the CCM, to be in the technical working group, need also effort, because not all community could involve sometimes. So for the government and the CCM in the country, I would recommend that please involve all the communities in those spaces in the meetings. So we are being updated not only in the early stage. And I understand that also there is a representation in the CCM from community, but especially for the youth, we are not having a specific chair in the CCM, but what we do is we need to make allies in the CCM community representatives. So we have some coordination and discussion. So if you are not in the CCM roles or you are not in those space, you could have some coordination and you could reach out to the CCM community member to give inputs and also take some update from them regarding the implementation. That's it.
I think that that's good advice to be taken across the board. Grace, if would you like to say a couple of words on this?
Yes, just to add on what the earlier speaker spoke about is there's a lot of work that has been done by CRG and some CSOs that get support from CRG, and it has been very helpful to us because the information sharing and information sessions that the CSOs organize with communities have really helped us to understand the processes and to understand that all the processes and all the cycles in Global Fund are important and why you should be in all the processes. So for me, I would recommend that to continue and more information sessions, and especially now we're talking about GC8 and integration, it should be more vigorous so that key population and all community members understand the importance of GC8 and what is happening. Thank you.
Thank you. I think that was very clear and concise, and it really speaks to we have a comment from Modest Mumbo, who I think is a passionate advocate for sex worker involvement, and she has commented, which I think is quite relevant, the sex worker organizations, and I think this is referring specifically to the DRC, but I'm sure refers to many other countries, are not involved, and it's really hard to know exactly what is being taken into account. So if you're not in the room and people aren't in the room, that is really difficult. And she says that the PR I think isn't providing information. So she's grateful that Grace, you brought up this, and that Bella brought this up as well. So we have a few minutes left. I have one key question, and for everybody who's online, all of the answered questions, please take a moment to have a look at the Q&A, because where questions have come up and they've been answered, they appear in the Q&A as well. So you can look at the questions and the answers already there. But one final question for everybody, and maybe we'll start with you, Antons, is if everybody who's on this webinar, they forget everything else that was said, what is one thing that you want them to remember and to take home? What's one piece of advice that somebody should go home with today? And so we'll start with you, Antons.
I think thanks for putting on the spot, but I think I had it on my conclusion remarks that I think there is enough evidence, there is enough guidance and all tools developed and published. I think in my presentation, in the end I was a bit surprised myself how many different tools are available. I think the main point is to use them and I think luckily we still have some capacity to provide technical support for countries, and if there is a need, I think both UNAIDS and WHO can try to help to navigate those tools and to make sure that the countries and the community organizations take the best from what is possible. Yeah, maybe that's the point. So we are here, and if you need something, that just reach out to WHO or UNAIDS or Global Prevention Coalition. Yeah, over.
Matteo, next to you.
Thank you, Heather. It's a difficult question, but I would say that, think that, we're in a very, very different situation this time around when you think about when we compare it against other cycles. Time-wise, we have little time, and funding-wise, we have, in many cases, less money. I think we really need to trying to, as much as possible, be collegial, be united as community representatives, as key population groups, trying as much as possible to be flexible and trying to, at times also compromise on some of our own priorities for the benefit of the whole group. So I do think that's one thing I would like to remind people to try and really be ready to share information, to work together as much as possible. Because it's not going to be easy, and difficult decisions need to be taken, but we need to be together if we want to succeed in this. Yeah, that's it.
Over to you.
Me?
Yes.
Sorry. Yes, yeah. Well, I would say for the community, keep your energy. It's a really tough time, and yeah, we understand that we like this reducing funds, but we also need to make sure that all the community priorities are put there in the proposal, and it's really important also to take a look and read all the Global Fund documents so we could really engage carefully and understand more of the processes so we could really monitor and also engage meaningfully in all this space of this funding request. And also, keep fighting. It's a really tough fight for us, but community needs to fight together. Thank you.
You remain engaged, fight, and be prepared. Grace, over to you for a short final thought. What should people go home with?
Yeah, what people should go home with is not everything is integratable. I don't know if that is English. Not everything is integratable, but I want to say that we can integrate KP services if we do it the right way.
I love it. That was so succinct. Perfect. We can do it if we do it the right way. And Barbara, the final word from you.
Okay, I really have many final words. I want to speak to what Grace has said, but just one is that meaningful engagement is not just invitation. It means that we have to have early involvement, supported participation, and meetings that are accessible to the community so that our decisions are shaped by community evidence. So that's what I'll say. Thank you,
I love
Heather.
that. And also, I really do. It's not just an invitation, but also the evidence that communities bring is so important. So we are almost at the end of this webinar. So what I want to do right now is to ask everybody who's here to please join me in giving a virtual thunderous round of applause to all of our speakers today, to Matteo, to Anton, to Barbara, to Grace, and to Bella. I also want to thank our colleagues at SSLN, in particular Paranita, Madonna and Carabo, and everybody else at SSLN for their partnership in organising this webinar and providing the logistical support. If you're here and you enjoyed our webinar, or if you didn't, please give us some feedback on the KP community of practice. There is a QR code on your screen. We do want to hear from you because we want to make this better. We want to make it more useful to you in any way that we can. So I think my final word is going to be that meaningful participation beyond the invitation of key populations and community-led organizations in planning and in writing is critical, but it should not just be limited to the writing and the planning, even though that's what we're doing right now. It has to be throughout the grant cycle, and we are all responsible for making sure that that engagement happens. It cannot be replaced. And so just a final reminder that the recording and all of the slides will be published on the SSLN and GPC websites, as well as on YouTube. And there will be another webinar with some different speakers, but the same themes in a few hours if you would like to hear some other country perspectives, for example. So with that, I will say thank you all very much for staying. Thank you to all our panelists, and have a lovely day.